Last speaker of the day for this session. It's
No one else?
yeah, Dr. Kripali said she is the presenting author. Optimizing IOL power in patients undergoing cataract surgery in eye myopia.
बाकी तो नहीं है ना last. It is there. Absent.
Good evening, everyone. My topic for today is optimizing IOL power calculations in patients undergoing cataract surgery in high myopia. So our aim is to optimize the refractive outcomes in high myopes undergoing cataract surgery with implantation of monofocal IOLs. The objective is to evaluate monovision outcomes and glass independence in these high myopes and to ensure the target refraction is achieved. So as we all know, the high myopia is defined as myopia more than or equal to -6 diopters or axial length of more than or equal to 26 millimeters. The incidence of high myopia is increasing rapidly, especially in the Asian countries. And correspondingly, as the most common complication of high myopia, the incidence of highly myopic cataract is increasing year by year. And it accounts for 30% of the total cataract surgeries in the tertiary hospitals. The patients with axial myopia, these are at risk for suboptimal refractive outcomes following the cataract surgery. Although the patients with normal axial length, they achieve the refractive outcome within the predicted 0.5 diopters in 67 to 72% of the cases, whereas only 54% of those with axial myopia, they attain the target refraction when no optimization method is used. The pre-op axial length determination, the post-op anterior chamber depth, and the effective lens position, these are the important causes for the inaccurate IOL power calculation in high myopes. So in our study, a total of 26 eyes of 13 patients were evaluated in the studies, and both the eyes had an axial length of greater than 26 millimeter, and the patient's ocular dominance was checked. The inclusion criteria being biometric measurements done only by IOL Master 700, and the cataract surgery was performed by phacoemulsification with in-the-bag IOL implantation, and both the eye cataract surgery was planned. The patients with previous intraocular surgeries or intraoperative or postoperative complications were excluded, and the patients with pre-existing ocular diseases such as keratoconus, corneal scarring, endothelial dystrophies, and retinal detachment were excluded. And the patients who underwent any combined surgical procedures were also excluded. And the patients with follow-up of less than 1 month. So our baseline characteristics of the study population was the age group was between 25 to 80 years. The axial length of all these patients was about 26 millimeters. It was between 26.24 to 35.02. And the IOL power target refraction emmetropia was -9.5 to 13.5. And the IOL power which was selected by the surgeons was between -7 to +13 diopters. And the IOL power implanted was the same. So without any financial interest, in 80% of the cases, the Acris of IQ and Acris of Expand was used. In 16% of the cases, Rayner Raven was used, and 4% cases had Sensar 3Ps. And IOL power optimization was done depending upon the IOL power which is obtained. So if the IOL power is between 0 to -10 diopter, the target refraction was kept as -2 diopters. If the IOL power is between the range of +1 to +10, in these cases the target refraction was kept as -1.5 diopters, and anywhere above 11 it was kept as -1 diopter. So this is the IOL Master 700 chart. Okay, the axial length of this patient is 35.02, and the Acris of Expanded is showing -5.5. Okay, so our optometrist had, he had put -4, but depending upon the other eye status and our nomogram which was placed, we had decided to go ahead with -3 diopters. So in our study, we found that 92% of the cases had achieved the uncorrected visual acuity of 6/9. Okay, and 4% was within the range of 6/12, and other 4 was 6/18. So to conclude, monovision was achieved in these high myopic patients, and thus these patients had less spectacle dependence. Post-op predicted refractive results were obtained in 92% of the cases. Fine-tuning glasses were advised to the patients, and monovision is a good option for spectacle independence because trifocal and multifocal IOL powers are not available in such high myopes. These are the references. Thank you, sir.
Thank you. I think that was quite a good study, and your topic was optimizing of the IOL power, and so you're happy with the optimizing nomograms that you're using?
Yes, sir. So our professor, Dr. Sri Ganesh, sir, he is talking with Professor Graham Barrett, and they are coming up with a nomogram, sir, regarding optimizing the IOL power.
Very much needed. Okay, so any observation about posterior staphyloma in these patients?
Yes, sir, they were there, sir.
Were there any surprises after?
No, sir. In 92% of the cases, the predicted outcome which was kept, it was achieved, sir, which was within the diopter to have that spectacle independence in these cases.
Sir? Okay, thank you.
Thank you, sir. Thank you, ma'am.